So we're going to transition. You've heard a lot about how we take care of our patients in terms of treatments and management, including clinical trials. And so we're going to transition now to how can we best support our patients and the caregivers. And so the next session will really focus on this. And I'd like to introduce the first speaker, Chris Weyer Jamora. She is a professor in the Department of Neurosurgery. She leads the neurocognitive clinic that is now embedded in neuro-oncology. So we're really, really so pleased that this is now an integrated part of how we take care of our patients. So she's going to speak about cognitive rehabilitation in brain tumor populations, the current state of the art. Thank you, Chris.
Thank you, Suzanne. I appreciate it. Let me share my slides. Well, I'm so excited to meet with folks today to talk about something that's near and dear to my heart and is increasingly becoming a huge part of how we're thinking at UCSF about the cognitive care of our patients. Really thinking about how cognitive rehabilitation can serve in the lives of our patients and managing the cognitive changes that they experience. I have no disclosures for today. So overall, thought that we would talk a little bit about reviewing some of the cognitive changes some of the common cognitive changes that our patients and caregivers come with, as well as current thinking about how cognitive rehabilitation can play a role in the management of that, and how we are translating some of these concepts that we're finding evidence for in the research to the clinical care that we provide our patients to be able to do that. So cognitive impairments are common to brain tumor. We know that, that we're finding learning disruptions in memory, executive functioning are all common to the brain tumor patients that we serve, and that irregardless of grade, high grade, low grade, or even meningioma, that we know that these individuals that we serve, that they have changes in their health-related quality of life as it relates to the cognitive impairments that they experience. Cognitive impairments are associated with lower rates of return to work, as well as strained interpersonal relationships and reduced quality of life, irregardless of their Karnofsky performance score. Additionally, issues such as anxiety, insomnia, depression, all can contribute to the functional expression of cognitive impairments. And so it's important for us to have a holistic picture whenever we're thinking about not just the cognitive impairments themselves, but also how other factors mediate that cognitive expression when we're thinking about how to meet the quality of life needs of our patients. So the prevalence of cognitive impairments, there's conflicting evidence in the literature in terms of how that plays out across the disease trajectory. There's some reports that cognition improves 3 to 6 months following tumor resection. However, other data suggest that many patients have persistent changes and or decline further, especially as it relates to the consequence of subsequent treatments such as radiation and chemotherapy and or tumor progression. And that comprehensive neuropsychological assessment early on in the course can allow for the development of a treatment plan by which to identify and also support individuals as they experience these cognitive and emotional vulnerabilities, particularly as it relates to from a strength perspective. I know a lot of times we're talking about cognitive impairments, and I myself have been talking most of that, been saying most of that in this talk. However, it's often the case that we need to think about the cognitive strengths that individuals have as it relates to their quality of life goals when we're thinking about putting together that care plan with them. We know that neuropsychological assessment can both bear out those strengths as well as vulnerabilities and put together a cohesive plan with the treatment team to be able to help support them through the disease trajectory. And that neuropsychological assessment is far more helpful and accurate than some screening tools such as the MOCA or just clinical interview alone. So what is cognitive rehabilitation? It really incorporates education, strategy, instruction, practice, and environmental interventions, both for the caregiver as well as the patient themselves. And the goal is really to improve their autonomy, their awareness of their challenges, as well as their strengths, and help with emotional coping and agility as they need to do things a bit differently than how they've had to do it before in terms of managing their day-to-day quality of life. So what does the literature say in terms of cognitive rehabilitation? What role does that play for some of these patients? So we're beginning to learn that there are different, cognitive rehabilitation is not a one size fits all. So there is different interventions. So for example, cognitive retraining, when you're just trying to get that skill, that attentional skill to be improved, where you're just kind of you're just focusing on that skill. Yang in 2014, using virtual reality, found that attention and memory can improve. And this was in a sample of meningioma, Matson glioma. There's limited evidence as a standalone, and this is also consistent with the TBI and stroke literature, using a cognitive retraining in terms of generalizability to one's daily life. So I get a lot of questions about brain games and other literature. And at this point, it really is we haven't seen a lot of good evidence for the use of those interventions in brain tumor patients, specifically if they're self-guided. There is some promise whenever it's combined with other treatments, which we'll talk a little bit more about. So in terms of cognitive strategy training, there is some more promising evidence in terms of attention and concentration, verbal memory, and executive functioning. This is some data from Richard, where he looked at individuals that had strategy training, so teaching them how to work around their challenges with organizational strategies such as calendaring and metacognitive, like catching yourself before you're making a mistake. And he found that was far superior than just giving them education alone. So just telling a patient, hey, you need to probably use your calendar, or hey, you probably need to pre-plan, that in of itself is not enough to really be able to get these gains that we see in cognitive rehabilitation. But it's actually the practice of that and the iterative work that patients do that is quite helpful. And this was in a mixed pathology, but there is small sample sizes. So again, this is still, we're still learning more about this promising intervention. And then when you combine retraining with strategy training, this is some work from Gehring that a few folks are probably familiar with, that you do get these changes in, durable changes in attention, concentration, verbal memory, and processing speed. So interestingly enough, those changes show up later on. So you can do a cognitive rehab course with strategy. You're teaching them how to work around their problems. You're retraining that attentional skill. But then it's not until a bit later that you see, oh, okay, well, it takes a little bit more time to consolidate those gains. So that slower consolidation, we think it's due to the underlying neuroplastic mechanism, that it takes time for practicing those strategies to be able to add additional stability to cognitive impulse the transmission. So we still don't understand that very well from a mechanistic perspective, but oftentimes patients will say, well, I feel like I'm still getting better, even though I've ended active treatment with you. Is that normal? And what we're seeing is that, yeah, actually patients can continue to improve functionally along the course and the trajectory. And we're hoping to understand that a little bit more as we have more natural history studies. So this is the study that we're doing at UCSF. So how do we take all this information and actually help our patients? So one way that we're trying to help our patients is really studying it in our population with a bigger sample, with one that is maybe histologically not as mixed, so we can really try to understand what elements are going to be helpful for patients at what time. So one thing that we're definitely seeing is the patients, when they're off active treatment, that's a very good time, both from a mechanistic perspective. If you think about the neuroplasticity, that there's some data that suggests that when patients are in the active edema phase, when they're in the active kind of inflammation phase, that the neuroplastic mechanisms are less available from a rehabilitation perspective. So we wait a little bit beyond that to make sure and take that into account whenever we're looking at cognitive rehabilitation and manage expectations. We know that some of our patients that can be frustrating because they want to really get to work. But at least in the Loglio trial, with the generous support of Ashley and Alan Dabiri, we've been able to really look at and find some promising results, especially as it relates to executive functioning and potentially learning to be able to understand that. And again, we're finding this later on down the line after treatment has ended, and we're hoping to have some more robust results for that soon. So clinically, this is how we're beginning to look at management of these patients in our multidisciplinary team meetings. So a patient and or caregiver talk about having some challenges in terms of their health-related quality of life as it relates to emotional and cognitive issues. And then we triage that from a multidisciplinary perspective. We have a medical nurse practitioner look at what are some of the medical factors. We're talking with a neuro-oncologist, we're talking with a surgeon. We're trying to really understand what's going on here. And if they're stable, medically stable, off active treatment, and can tolerate cognitive testing, that's when we're really looking at the cog rehab clinical pathway. So that means patients that are actively on really heavy duty steroids, where we might do some cognitive screening or some kind of cognitive education, where we're not going fully down the cognitive rehabilitation pathway at that point. We're waiting for individuals to get a bit more stable and to be able to provide a bit more intervention in that regard. And then if they're not medically stable, then we provide more of a focus on functional gains. So, and then after that, we go back for multidisciplinary review to see how it is that we can help these patients to develop those treatment plans. So some of the best practices that we're finding is that psychiatric and medical stability are very, very important, that patients have a hard time tolerating intensive cognitive rehabilitation if they have a lot of emotional distress and or medical instability. And it's tricky if a patient is on treatment, so wanting to make sure and keep that in mind. We're hoping our opinion continues to develop around what types of treatment are more arduous. Usually it's more the full cycles of Timidor and steroids, but we're continuing to look at that. And that cognitive severity rather than pathology makes a difference. That I see high-grade patients, I see meningioma patients, that it's not necessary, and that we see gains in terms of their return back to work, and also resumption of health-related quality of life activities. However, that their level of cognitive impairment, such as if they have mild to low moderate cognitive impairments, they have a different treatment trajectory and course rather than if they have more severe cognitive impairments, and that we need to kind of move between those those interventional sets. And that having a strength-based approach is very important for engagement, that many of our patients are struggling with enough, and just helping them to understand where their cognitive strengths are and how they can leverage those strengths is a huge part of reducing some of the difficulties around wanting to engage in such a challenging intervention. Longer-term follow-up is very crucial for detecting durability, and that tiers of care that involve both the caregiver and the patient are very important. Oftentimes it's a dyadic approach that we're taking in cognitive rehabilitation, where we're incorporating the caregiver as they are able to, as well as the patient, so that way it can additionally support intervention in the environment that the patient is in. The clearer the goal, the better. We want to integrate theory and practical application, but a patient really, the best times is when they have a specific goal, and that we can help them with that goal to then move forward. And that oftentimes that means a variety of aspects that we're incorporating into their care. So we have this work is not at all possible without our many teams that participate in this care. And I'm very grateful for all the hard work that folks have put in, and to learn more about how we can manage this with our patients. Thank you.